Yes, I welcome all of you for this evening program. That's the IFS South Tamil Nadu chapter monthly CME. Let's start the program with the prayer song.
கருவாக்கி உருவாக்கி எனையாண்டு காத்தருளும் இறைவா நன்றி. எங்கும் நிறைந்தோனே எல்லை இலாதானே, எங்கேயும் எப்போதும் என் குலம் காப்பவனே. நெஞ்சம் துணிய துணையாய் வருவாய், நேர்மறை உணர்வுகள் பெருகிடச் செய்வாய். உடலில் உறுதியை பெரிதாய் தருவாய், உனை உணரும் அறிவை என்னுள்ளருள்வாய். சுற்றமனைத்தும் காப்பவனே, செய்தொழிலில் ஏற்றம் தருபவனே, எடுத்த செயலில் வெற்றி கொடு, என் ஆற்றல் பெருகிட அருளை கொடு.
Thank you. Now I request our patron Dr. Ramni to welcome the speaker and the audience.
Good evening all. Dear Dr. Seema Pandey, who is going to be the speaker for the day today, I welcome you on behalf of IFS South Tamil Nadu, as well as I also welcome all the members who have joined this IFS South Tamil Nadu program today evening. Dr. Seema is a director and a chief consultant of Eva Fertility and Vanshati, and she has been a librarian. She got elected as a librarian ISAR for this year, 2024 to 26. She has been a managing committee member of ISPAT and COMHAD. I don't know what it is. Anyway, 2023 and 2025. And she is currently the president of Azamgar OBGYN Society. And she has done her fellowship in minimal access surgery, regenerative medicine, as well as stem cells, and diploma in ultrasound. So put together endoscopy, regenerative medicine, FRM, and the ultrasound, I think she is one person who can have ART under one roof. And today I have great pleasure in welcoming her for today's evening program to give a talk on polycystic ovarian disease, which is one of the common anovulatory problems what we see, and it needs both for non-ART as well as for ART conceptions. It may differ, but I think last time we had ART conception, and this time we were expecting the talk from Seema towards the ovulation induction in ART conception. Welcome, Dr. Seema.
Thank you so much, ma'am, for your kind words. COMHAD is Commonwealth Association of Health and Disability, and I am one of the managing committee members for India chapter. It reports to Queen or King of England.
Very good, very good.
Great, Seema.
Very good.
Thank you, Dr. Chitra ma'am and ma'am.
Now, as a secretary of the society, I have the duty to tell you about the last meeting. The last meeting was on February 28, 2024. It was again a webinar, and the topic for discussion was troubleshooting in ART, and the speaker was Ritu Hinduja. We had good number of attendants, about 50 of them there with us, and it was a good discussion following the talk because she was going segmentally in all areas. So there were a lot of questions, and it was a very interactive session. Thank you very much. And then now I think we'll move on to the scientific session. Over to you, Dr. Seema.
Thank you, ma'am. And I would like that kind of bilateral discussion here. So let's learn from each other. And wherever there is some question, you can stop me and we'll take from there, ma'am.
No, actually, I asked them to put it on the chat box so that there's no confusion. So you can keep, if there are questions, you can answer them and then and there. Yes.
Okay, ma'am.
All
So
of you all
let
can
me,
put your doubts on the chat box.
let me share my, yes. So, respected Dr. Ramani Devi, can you hear me?
Following your talk, our ICOG. Yeah, yeah. Yes, yes.
Yes, ma'am.
Yes,
Mark your,
we can hear you. Go ahead.
So should I start?
yes, yes.
Yes, you
So,
can go ahead.
as Madam has told that it is ovulation induction and PCOS ART, why are we calling it ovulation induction? Because we all know that polycystic ovarian syndrome is a chronic and ovulatory condition, which etiology wise a polygenic, polyfactorial, systemic inflammatory autoimmune disease with dysregulated steroid state, manifesting largely due to lifestyle error. And we also know that it is the most common heterogeneous female disorder, endocrine disorder. Around 20% is the prevalence, which is just a tip of iceberg. And majority of us, including myself, believe that polycystic ovarian syndrome is a metabolic disease with underlying ovarian defect. And insulin resistance, obesity, infertility, cardiovascular problems, and psychological issues are its comorbidities. So if we look at the N ovulation, the problem of N ovulation, if you are looking at 80% of this women are suffering from polycystic ovarian syndrome, and 9 to 18% of women, as I told, 20%, it differs from state, even geographical area within India. So environmental toxics, genetic predisposition, now the new kid on the block, gut dysbiosis, along with lifestyle, all these things lead to three conditions which are hallmark for polycystic ovarian syndrome, and they contribute to the pathology of chronic anovulation and why they make these women different from normal women having infertility. So first is there is hyperallergenemia, second is hyperandrogenemia, and second is insulin resistance, and that is the reason. So all these extra ovarian factors, what do they do? From the brain, they will secrete, increase LH by amplitude and quantity, both will be increased. From this lifestyle factors, there will be dyslipidemia, obesity leading to inflammation, and that will act on adrenals, and that will give rise to extra androgens. And pancreas, because of insulin resistance, their body require more amount of insulin to metabolize that exact amount of food which any other woman could be doing in lesser amount. And all these factors, they insult the ovary, and ovary in retaliation secretes more quantity of testosterone, AMH, VGF, EGF, all those factors, and there is decreased atresia. So what all these things, whenever I'm talking about all these alterations, I'm talking about LH, hyperandrogenemia, hyperinsulinemia, and though obesity is not part of that Rotterdam's criteria or any diagnostic criteria, but we have to believe this, that obesity or high BMI makes situation worse for these polycystic ovarian syndrome, and it has some kind of integral association with that, or idiosyncratic kind of association with polycystic ovarian syndrome. So this persistent LH hypersecretion, which is tetanic, that is going to alter the activation of meiotic process, and there is a defective meiotic maturation, there is defective cytoplasmic maturation, and epigenetic maturation, which is largely due to intra-ovarian hyperandrogenism. At the same time, hyperinsulinemia causes follicular recruitment increment for the follicle size 3 to 5 mm, and we know after that there is follicular arrest. All these conditions, they vary as per the phenotype. Like phenotype A and B will be having the higher amount of LH, higher amount of androgen, insulin resistance, and obesity. So they are associated with all these situations together, and that makes our phenotype A and B tough to stimulate. And if we are stimulating them, they require larger quantity of gonadotropin to get a follicle recruited. And here in ART cycle, we are talking about multiple follicular recruitment. So first concept, whenever I am talking about this recruitment, I always try to revise the concept of FSH threshold and FSH window. So that minimal quantity of gonadotropin which is required to recruit a follicle is higher in phenotype A and B as compared to phenotype C and D. Here, a quick revision. Phenotype A is having all the three features of Rotterdam criteria: hyperandrogenemia, ovulatory dysfunction, and polycystic ovarian morphology, while phenotype B is having hyperandrogenemia, ovulatory dysfunction, but their ovaries are normal. So, and while phenotype C is ovulatory PCOS and phenotype D is the docile one where there is only ovulatory dysfunction and hyperandrogenemia, and the easiest group to treat. So this phenotypic division gives us some insight in counseling and deciding. And all these factors together, they make polycystic ovarian population different than normal population. As we start the ovulation induction, we are talking about COH, but we are doing ovulation induction because these people are chronic and ovulatory. So in these patients, they require slightly longer stimulation, around on an average 1.2 day extra day of stimulation is required. And as we all know, polycystic ovarian syndrome patient, either they don't respond to your stimulation or they just hyper respond. Phenotype A and B are tough to stimulate, while phenotype C and D, they will give lot of follicles once you start. So you have to be very careful and you have to take care of that, and counseling should be done accordingly. So there is high number of developing follicle leading to large number of cumulus oocyte complexes and granulosa cell of these complexes. It is going to secrete lot of estradiol level, and this makes PCOS population at greater risk of having a dreaded man-made complication called ovarian hyperstimulation syndrome. And as I told you, resistant PCOS like phenotype A and B, longer the duration of amenorrhea, scanty is the menses, and higher is the BMI. These three things make any polycystic ovarian syndrome patient a resistant PCOS, and their threshold is higher than normal, and they practically behave like a poor responder. So suppose you had a previous cycle where you had stopped your stimulation and 225, she did not respond to. Next time you'll have to start with 300 or minimal that quantity of gonadotropin. And polycystic ovarian syndrome patient, one get pregnant, they are at higher risk of miscarriages because of impaired endometrial receptivity and increased embryonal aneuploidy or both together. And we have to understand that these people, polycystic ovarian syndrome is a factor responsible for that. Along with this, insulin resistance, hyperandrogenemia, and obesity are independent denominator to cause miscarriages. So all these together, they put these women at higher risk of miscarriages. As I was discussing, phenotype A had this study I keep quoting. This is from our Dr. K.D. Nair group from Delhi, where they have studied the response as per phenotypic presentation expression, and they found that the OHSS was highest in phenotype A, while phenotype B was the most resistant to stimulate and required highest doses. Phenotype C gave lowest pregnancy rate because of the highest hyperandrogenemia, while our D had the highest pregnancy rate. So whenever we are going to stimulate a polycystic ovarian syndrome patient or anyone who is planning pregnancy, pre-pregnancy optimization is very important. Pre-pregnancy optimization in terms of folic acid intake, cessation of smoking, alcohol, other occupational things is okay. But these polycystic ovarian syndrome patients, they have to be told in detail about lifestyle modification and supplementation of vitamin D or insulin sensitizers like metformin, and we have to choose the groups as per their elevated age specific AMH. Vitamin D is decreased in spite of staying in sun throughout the year. Our population is suffering from vitamin D. I don't know how much it is created or how much it really matters, but vitamin D supplementation has become like a rule for all these patients. You know, don't need to check the vitamin D level. And as per PCOS guideline 2023, if you are giving metformin as an insulin sensitizer before 2 months of your ART, starting your ART injections, that is good. So whenever you are counseling these patients, you have to discuss the adverse impact of weight, because most of these people, for them, decreasing weight is a big problem, but they are in hurry for pregnancy. So their impact of weight on clinical pregnancy, miscarriage, live birth rates following infertility treatment. And these are the lines as it is written in guideline 2023, that a reproductive life plan and age appropriate education on optimizing reproductive health is recommended in adolescents and women with PCOS. So this chart is total now. This patient is already been optimized. She has been kept on metformin. Now comes the time for stimulation. A cycle before pre-treatment, it is very much in vogue nowadays. So we have few agents for pre-treatment. Our commonest one is oral contraceptive pills. When all of us were a student of this reproductive medicine, majority of us were doing our cycles in batches, and there all our patients were used to be kept on oral contraceptive pills to just synchronize the menstrual period of all the patients together. And later on, it was found that giving oral contraceptive pill as pre-treatment decreases live birth rate and more in an antagonist protocol. So you should avoid COCs as much as possible for pre-treatment, either for synchronizing or for any other purpose. Estradiol is the commonest pre-treatment modality being used, especially for poor responder. Here we want the follicular synchronization, so that we give estradiol from day 21 till the day you want to start the stimulation. And this is the most favorite pre-treatment as of now, and it can be used for that purposes. But let me tell you, whatever entity I'm going to talk about, apart from oral contraceptive pill, which clearly decreases the live birth rate, rest of these estradiol, progesterone, early antagonist start protocol, none of these pre-treatments increase the live birth rate. Progesterone is given basically for menstrual withdrawal, as our country females are very much they always want that their menstrual cycle should be regular, and if we start the menses without giving this withdrawal, they are not at ease. But literature shows that giving withdrawal and doing stimulation later on decreases the response. So if possible, it shouldn't be done, but we have to do it. So 5 to 7 days of hormone free period we are following right now. In many of the cases where you are suspecting that the last cycle stimulation went bad, recruitment did not take place, the culprit was hyperallergenemia. in those cases, you don't have to give COCs anymore. You can always give an early start antagonist protocol where you have to give 3 doses of antagonist starting from day 1 or 2 of the cycle, followed by stimulation. Let's look at the evidence. As per this ovarian stimulation for IVF XC guideline HRA 2021, these protocols, they don't increase the live birth rate, and they are just good for synchronization and scheduling, nothing else. Coming to the protocol, the favorite most protocol for polycystic ovarian syndrome is antagonist protocol, followed by segmental. This is called segmental IVF protocol, where first of all, we do the stimulation with antagonist protocol. We give agonist trigger, then we freeze all, and then we do the embryo transfer later on, and this is called segmented protocol. So this is antagonist protocol is the most favorite protocol among all these protocols. And step-up protocol. For polycystic ovarian syndrome, they are hyper responders. OHSS is not only dose dependent for them, they have idiosyncratic affiliation for OHSS. So even 150, you have kept a patient on 150 international unit of gonadotropin, they can also do bring ovarian hyperstimulation. So antagonist protocol is the best protocol. Then comes progesterone prime stimulation protocol. This is relatively new kid on the block. It takes care of the progesterone prime, of the premature LH surge and premature luteinization very nicely. And I will talk later about this. And as I told you, step up protocol, you start with the minimal dose of gonadotropin whenever you are planning an IVF cycle for a polycystic ovarian syndrome patient. You start with the minimal dose. You give a gap of 5 to 7 days for going up, and the doses by which you are going to go up should not exceed 50%. And once you get the recruitment, you have to continue on the same dose for almost 10 to 12 days. Once your lead follicle becomes 18 plus, you should be giving the trigger, and trigger should be agonist trigger. It should not be a CG trigger. Sometimes dual trigger can be given, but for that you need lot of expertise. So you should not venture into these other protocols until unless you are really pro with your stimulation, proper conventional stimulation protocol. Whenever we are talking about stimulation or ovulation induction in PCOS, majority of time we are talking about conventional protocol. A long agonist protocol and antagonist protocol, even progesterone prime stimulation protocol, all these follow conventional protocol strategy, while the minimal stimulation or mild stimulation protocol is that where we cut out the doses of gonadotropin to decrease the chances of ovarian hyperstimulation syndrome. So majority of time we are talking about conventional dose protocol whenever I am talking about any protocol. Then next question is HMG versus FSH. Even now, people believe that since polycystic ovarian syndrome patient have hyperallergenemia, they should not be given HMG. But this is a myth, let me tell you. HMG and FSH work almost similar. And here I love to quote these studies, one from way back 1969-70. That was a randomized double-blind crossover study over 12 patients, and they were stimulated with FSH and HMG in 3 alternate cycle. Various parameters like FSH, LH, estradiol, DHEA levels were noted down, and they found there was no significant difference in endocrine changes, and even clinical and ultrasonic observation did not support the theory that treatment of infertility in PCOS with FSH is safer than HMG. Then came 2020, and this my favorite trial, Megaset trial. It was to evaluate the efficacy and safety of highly purified HPHMG against recombinant FSH. It was a randomized, open label, assessor blinded study, and it was done on hyperresponders with AMH more than 5 nanogram per ml. And the main outcome measures were ongoing pregnancy rate after fresh transfer, as well as after FET, in terms of cumulative live birth rate and chances of ovarian hyperstimulation. Look at this chart. HPHMG, our highly purified HMG, has been doing best at every place, be it fresh cycle transfer, FET transfer, cumulative rate, and look at the miscarriage rate. It is just almost half of the recombinant FSH group, which even the authors could not explain what was the reason. So, people, next time when you are planning your stimulation protocol for a polycystic ovarian syndrome patient and your patient cannot afford recombinant FSH, you should always go with HPHMG without any doubt. And HMG decreases the chances of ovarian hyperstimulation syndrome as well. So it is win-win situation from all the side. So I will talk individually about these protocols as I had discussed long protocol, antagonist, PPOS, and minimal stimulation. So the decision is always done by AMH, AFC, BMI, and age. And it was seen that obese polycystic ovarian women, as I have already told you, they behave like resistant PCOS or poor responder. They require longer duration and higher doses of gonadotropin with poorer response. And GnRH agonist versus antagonist, the influence of body mass index, it was found that in patients with BMI more than 25, COH with either agonist or antagonist achieved comparable outcome, while it was seen that people who had BMI less than 25, their agonist got better results. But this is really scary, and I will just suggest against going for long agonist protocol for the beginners in polycystic ovarian syndrome, because it can explode anytime and you don't have a flexibility of choosing your trigger. So please don't do it. Can AMH level predict the need for increased medication during IVF ICSI in PCOS patient? This was also this study has also concluded that PCOS with AMH more than 4.6 nanogram per ml are resistant to HMG stimulation, and they require dose step up during ART cycle and are at higher risk for severe OHSS. So that increment should be done very properly. Excess AMH always play a role in characteristic follicular arrest. AMH is a gatekeeper which doesn't let pre-antral follicles to enter into antral pool and become FSS sensitive. So higher the AMH, resistant would be the patient for your gonadotropin to act. And this is due to a negative action on aromatase expression and on FSH action, I has told you. So when we talk about agonist versus antagonist, why do we prefer antagonists? Because the first and foremost criteria is that relative OHSS free clinic. Antagonist protocol gives us flexibility of choosing agonist as trigger. So there are lower OHSS rate, lower gonadotropin doses because there is no over suppression. It causes immediate blockade, receptor blockade, lower stimulation duration. We don't have to start from before the cycle. And since there is no over suppression, we don't require higher, longer duration. Lower flexibility of choosing a trigger, as I have already told you. But let me tell you one thing, that the number of eggs and live birth rate are slightly better with agonist protocol, but we are avoiding those benefits just because we want that our patient should be safe. So this meta-analysis is a big meta-analysis, and it was done and all the parameters like gonadotropin levels, stimulation duration, endometrial thickness, E2 level, retrieved oocyte, and com- mm, ongoing pregnancy rate, live birth rate, miscarriage rate, all the parameters were studied, and they found there was hardly any difference between agonist and antagonist protocol. And conventional GnRH antagonist protocol is a safer and more cost-effective choice for PCOS women undergoing IVF and ICSI. The reason why I am repeating it again and again, because later in my talk, I'll be talking about other modalities, newer applications. So please don't get confused. Those are experimental things. So antagonist protocol, we know that we have fixed dose protocol, we have flexible dose protocol. In fixed dose protocol, we start our antagonist on 6th day of our stimulation cycle. While in flexible protocol, we wait for our follicle to become 13 or 14 or our E2 to cross 300 nanogram picogram, I'm just forgetting, per ml. But in polycystic ovarian syndrome patient, early start of antagonist on day 5 is preferred, and contrary to belief, it not only takes better control of LH surge, it decreases the total stimulation duration and doses required, and better quality embryo and higher live birth rates have been reported when you have started early start antagonists. Now I'm coming to mild versus conventional. So conventional protocol was based on the fact that this woman who's undergoing stimulation, she should be completing her family within one IVF cycle, one egg retrieval cycle. So more is the better was the concept. But later on, and when we got antagonists, we got more frank and like relaxed. And we thought, let it be, even if we get 25 to 30 oocytes, we have we have this provided this clinic is OS, we have agonist trigger. So even if our number goes higher for the oocyte, since we have agonist trigger, we can always stop having this OHSS, and one cycle we will get sufficient amount of embryos so that this patient can complete her family. So this was more is better was the uh, policy, but it was later thought that it doesn't work that way. Risk of OHSS is not eliminated completely, and later on FET cycles its epigenetic effect on fetus, and effect of without corpus luteum estradiol to the woman led to perinatal complication, has just brought us back to mild stimulation, a protocol in which the ovaries are stimulated with gonadotropin and or oral ovulogens like letrozole or clomiphene, and we want to get fix 6, 7, 8 oocytes. Here we use fix 150 international unit of gonadotropin along with either letrozole or clomiphene, and this policy is based on the concept of eliminating OHSS and completing a family from single oocyte does not work here. So we want our patient to be really safe and minimal stimulation. We do not create supraphysiological level of estradiol, and we are trying to give a fresh cycle transfer. So conventional cycle in PCOS does not allow you for fresh transfer. We should not be doing because of the danger of primary after that secondary OHSS. So minimal stimulation protocol was tried in polycystic ovarian population, and they found that it does good, and as it is at par with our conventional so protocol. Mm, so where can you do this protocol? this study has just studied polycystic ovarian syndrome patient, and they found that minimal stimulation protocol works best in non-obese PCOS who are pre-treated with metformin. Can you just stop? I'm getting some disturbance. So, whenever a patient of polycystic ovarian syndrome is with you, or any patient where you want to carry out an ART cycle, individualized protocol should be preferred, which should be based on AMH, AFC, and other factors, and it helps you to increase the success of ART. At the same time, it decreases the stress, cost, and complications. There are other innovative protocols. This I will tell later. First of all, I want to talk about progesterone prime stimulation. It was first reported by Kwong and colleagues who used medroxyprogesterone acetate as an oral replacement for antagonists to prevent premature LH surge in women undergoing COH for IVF. The reason they chose MPA was that it has moderate to strong progestational activity and fewer androgenic property, and it does not interfere with measurement of endogenous progesterone. And it was this concept came from looking at the oral contraceptive pills being used for family planning which prevent ovulation. It was in 1915 or 16 when Wong and colleagues, they published first RCT on polycystic ovarian using PPOS in polycystic ovarian syndrome patient. So this progesterone, it by decreasing GnRH pulse frequency and blocking E2 induced gonadotropin surge, it decreases LH pulsatility, and that brings out the correction of abnormally high LH HA, leading to bad quality of oocytes. So there is better oocyte maturation and quality. So how do we do it? In a conventional antagonist cycle, you start the gonadotropin on day 3, and you give either fixed or flexible antagonist starting from day 5 or 6 of the stimulation. While in PPOS protocol, you start your progesterone along with your gonadotropin, and you continue it till the day of trigger. You have to just make sure that your patient does not forget this tablet. Any progesterone with milder androgenic activity can be used. Favorite is medroxyprogesterone acetate, 10 milligram per day. I use 10 milligram twice a day, and I've got such a beautiful control over LH and premature luteinization. Even gonadotropin doses, I don't think that it increases. Apart from medroxyprogesterone, you can also use dydrogesterone 10 milligram twice a day, or natural micronized progesterone 200 milligram per day per vaginum. The next thing which can be patient friendly is progestin primed ovarian stimulation using calitropin alpha, that is long acting gonadotropin, along with PPOS. And that can PPOS, what is the advantage? The number of injection decreases. The cost effectivity is there, since you are going to do the freeze all, your 5 or 6 injections, patient is going to receive less, and at the same time she is going to be freeze all. Only negative factor of PPOS is that you cannot do fresh transfer. That is also being eliminated. What if daily doses of gonadotropin are replaced by these long acting gonadotropin injections? That can make life much easier for our ART patients. But as I told you earlier, all these protocols, they are experimental protocols, and any beginner should not be using it. So coming back to progesterone primed stimulation, this is a very good protocol for hyper responders like polycystic ovarian syndrome, your donor recipient cycle, as it is convenient, cost effective, good tolerability, no adverse effect on oocyte and embryos have been noted down, and there is in PCOS population, there is possible improvement in embryo quality and endometrial receptivity. At the same time, I would like to tell that the other studies where PPOS was being tried for poor responders, normal responders, they have noticed that any woman her age is more than 35, who has history of recurrent abortions and recurrent or history of aneuploidy miscarriages, PPOS protocol should be avoided in those patients. Fresh embryo transfer is not possible, and those patients where you could be doing fresh transfer as well, their cost may go high. People say that long-term neonatal outcome must be observed. It's been only 9 years since this protocol has come into existence. So we'll have to wait for the reports on neonates. Whatever reports have come till now, they are very positive, and high requirement of gonadotropin doses is the only thing which is going to be associated with PPOS in these cases. Lesser number of blastocyst formation is probably the way it controls the ovarian hyperstimulation syndrome better than antagonist protocol. So, what is the recommendation? As per this ovarian stimulation HRA guideline 2019, the use of progestin for LH peak suppression is probably not recommended. But we have to remember that it is 2024 now, and we should be having more evidence in favor of progesterone primed stimulation. Coming back to this long-acting GnRH antagonist protocol. This protocol is exactly like long-acting agonist protocol, where if you are using a depot protocol, you give it on day 21 of the previous cycle, and then you start your stimulation 10 to 14 days later from day 2-3 of the cycle. In this long-acting GnRH protocol, and long-acting antagonist is given on a day 24 of previous cycle as a bolus injection, and gonadotropins can be started from day 2 to 8, and we keep following till the trigger day, and we keep adjusting the doses. And the study found the non-inferiority trial, it has found that long antagonist protocol had better pregnancy rate in this particular study, which was published in 2019 and was done on 59 women in one group and 54 women in another group. So that is also a possible way of doing by making all these inventions are being done to make our patients' life easier. So if I want to just summarize all the protocols here before I go into the newer protocols, long protocol, the disadvantages, longer duration of stimulation, increased dose requirement. We have no trigger choice, only SCG can be given. So the chances of OHSS are very high. Though the number of oocytes, fresh embryo is very good, fresh embryo transfer is possible, clinical pregnancy rate is good, and miscarriage is at par. Antagonist cycle duration dose is shorter, lower, SCG, agonist, dual, any kind of trigger is given. So the chances of ovarian hyperstimulation are very less. Number of oocytes are 1 or 2 oocytes, you get lesser in number. Fresh embryo transfer is possible only with dual trigger, not otherwise. Clinical pregnancy rate is good and miscarriage rate is at par. Same goes with PPOS protocol. Duration is almost as it is in antagonist protocol. Dose requirement is higher. You can use any kind of trigger. The chances of OHSS are very high. Don't go on these arrows. I forgot to make 2 more. And number of oocytes are at par with antagonist. Fresh embryo transfer is not possible at all. Clinical pregnancy rate, live birth rate is good, and miscarriage rate is at par. Now coming to the use of metformin, that is all the evidence is always waxing and waning for metformin. If you remember the days of 2005 to 6 when metformin was the favorite kit for all the PCO patient, later on a phase came when nobody was using metformin. Now again, since 2018 guideline, metformin can be given anywhere if your protocol is not working, if you are not getting pregnancy, if menstrual regularity is not taking place, if your weight is not decreasing, use metformin. So in GnRH agonist protocol, metformin increases clinical pregnancy rate, but there is no evidence of improved live birth rate. While shocking is that in GnRH antagonist protocol, metformin is said to decrease the live birth rate, but it decreases the OHSS. That is very, very clear. And the effect on miscarriage rate is still uncertain. As per 2020 Cochrane conclusion, metformin treatment should be considered for the patients who are obese and undergoing IVF-XC, and they should be told about all the possible complications. So, myoinositol is the second kid on the block for as insulin resistant insulin sensitizer in a dose of 4 grams per day for 3 months prior to ovarian stimulation. Was found to be effective in normalizing ovarian function, improving oocyte and embryo quality in polycystic ovarian syndrome. In addition, it is cost effective and there is no side effect. So now I'll go to the newer protocols. I am talking about, when I was talking about minimal stimulation protocol, we were talking about adding oral ovulogen to our gonadotropin. So suppose you have started your stimulation with even with conventional or minimal stimulation protocol, where you have added letrozole from day 2 for 5 days along with your gonadotropin. This letrozole is going to decrease the overall requirement of the gonadotropin required for your stimulation. It is also going to take care of supraphysiological level of letrozole, of estradiol. And later on, if you continue this letrozole post pickup, it decreases the chances of ovarian hyperstimulation syndrome. So there were 3 ways letrozole was being used in ART stimulation for polycystic ovarian syndrome: as a mild or minimal stimulation, where you give it for 5 days in the beginning from day 2 along with your gonadotropins, 150 or 225 fixed protocol, mainly 150. Second way is when your estradiol level goes very high at beyond 5,000, you start letrozole and you stop on the day of trigger. And third way is that you restart the same thing after your OPU is done and continue it for a week. That takes care of moderate to severe hyperstimulation. So that is something new which is being done in the field of PCOS stimulation in ART apart from our conventional. Now, 2023 guideline has included this GLP-1, glucagon-like peptide 1, mainly liraglutide, semaglutide, all these. They might represent interesting molecules to tackle the weight axis that is associated with metabolic abnormalities, hyperandrogenism, infertility, and menstrual alteration in PCOS women. But when it comes to, these are the various places where GLP-1 acts. First is hyperinsulinemia, then hypothalamus, it decreases the pulsatility, and on obesity, for which it is really in vogue nowadays. And here it is also working. But believe me, I tried to find a new paper where the effect of liraglutide or any GLP-1 on IVF outcome was done. I could only find this study, which was done in 2018, where patients were divided into 2 groups. One group had 1 gram of metformin as pre-treatment, while the second group had 1 gram metformin along with liraglutide in lower doses, 1.2 milligram subcutaneous every day. And what did they found? That weight loss was not much different in both the groups. The combined group lost 7.5 on an average, while the metformin group lost only 7 kg. What interesting was that the pregnancy rate per ET was significantly higher in the combination group, as high as 85.7%, compared with metformin, which was 28.5%. And the cumulative pregnancy rate in the time frame of 12 months was 69% in the combo group compared to 35% in the met group, almost half. So they concluded that preconception intervention with low dose liraglutide added to metformin is superior to metformin alone in increasing pregnancy rate per embryo transfer. So resistant PCOS, I have already talked about, behaves like poor responder, respond to very high dose of gonadotropin. It could be because of high AMH or receptor polymorphism. But the good news is that both these groups respond to higher starting dose of gonadotropin, and getting receptor polymorphism is not important. In any stimulation protocol, especially for polycystic ovarian syndrome patient, you have to have OHSS prevention tools. That job starts the moment you decide and for undergoing ART for your patient. You have to do pre-pregnancy optimization in terms of weight control, giving her metformin 1 or 2 months before, then flexible step-up doses of protocols for gonadotropin, trigger modification from agonist preferably to dual sliding scale dual trigger. What is sliding scale dual trigger? Sliding scale dual trigger means that the SCG, the quantity of SCG you will decide as per the number of follicles and estradiol. It could be 1000 to 5000. And strict and tight monitoring, segmentation of the cycle. Metformin, I've already told you. Cabergoline decreases VEGF. So letrozole, I have already talked about. And antagonists, we have been using. All these are. This is a study we have been doing, and nowadays we are following this regimen for last 5 years. Post pickup, any patient whose E2 is more than 3500 or hyperresponder, we start on letrozole for a week, and these patients, we found that we never had to admit them for any kind of complication of related to ovarian hyperstimulation syndrome, especially a severe one. So I will conclude my talk by telling that polycystic ovarian syndrome patients are special women. They require pre-pregnancy optimization in terms of weight, lifestyle, vitamin D, and metformin supplementation. Antagonist protocol with agonist trigger is the favorite protocol, most effective protocol for OHSS free PCOS stimulation with segmentation of the cycle by doing freeze-all and FET transfer. And phenotype A and B are toughest to stimulate and are prone to get OHSS along with poorer CPR and LBR. Progesterone prime stimulation is cheap, convenient for PCOS in a segmented IVF cycle. And long-acting antagonist in luteal phase is effective in downregulating and represents a possible new protocol that will allow cycle programming and also eradicate OHSS. Agonist trigger is the best trigger. Pre-treatment, as I told, is best. And letrozole is a cheap and convenient drug, not only for preventing OHSS, but also using for mild or minimal stimulation. So I would just end my talk by this quote that wisdom is not a product of schooling, but of the lifelong attempt to acquire it. Thank you so much, IFS chapter Tamil Nadu, for giving me this opportunity, Ramani Devi ma'am, Chitra ma'am, and I'm open to any question.
Thank you, Dr. Seema, for that wonderful talk. Yes, we have a couple of questions on the chat box. Before that, can you just tell us about the letrozole dose, what you will give to prevent OHSS?
So the same dose we are giving 2.5 milligram BD. I'm in 5 milligram.
BD for 7 days.
Yes. And majority of them, the beauty is they get their menses in that week following. So
It gives us a sigh of relief.
exactly.
Okay.
Yeah.
Harshni has asked about, drilling, role of drilling before stimulation in resistant patients.
So I don't believe in drilling.
Okay, though
And
you're a
as I
laparoscopic surgeon.
Yeah, as I told in my talk that first of all, the effect of drilling remains only for 6 months. It is not superior to gonadotropin. It is not superior to even letrozole plus metformin combination. So, and it gives peri-op combination complications along with decreased AMH. So, if you are going for IVF, I don't think there is any role of drilling. Even if this patient is a resistant PCOS, you can, by increasing the dose, you can achieve the stimulation and recruitment.
See, but one thing, Seema, sometimes these patients may not be willing for ART, like because of this
Yes.
cost.
Yes, ma'am.
Maybe, and if you think that the patient has got other problems like a tubal factor or an unexplained
Exactly, ma'am.
infertility, like maybe in those cases we can try that. And we must remember that for drilling is useful only in lean PCOS, not in obese. And where LH is high, that is one important point. Okay, then it was a
Yes,
wonderful
ma'am.
presentation. Like GLP-1 use only today. Today only I came to know about it. See, you have been telling about the ovarian hyperstimulation syndrome, how to prevent it. See, yeah, today we had a ovarian hyperstimulation syndrome after a very, 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 very long time, probably years, no, Chitra. So
Yeah.
that this patient was more, I mean, like her BMI was within normal limits, put on metformin, PCOS, stimulated with combination of recombinant and HMG and GnRH antagonist trigger. She had 28 oocytes. So we know that she's going to go in for hyperstimulation. We have started her on even on the day of stimulation with the, day of trigger with gabergolin, followed up with letrozole and antagonist. In spite of that, on day 5 after the oocyte pickup, she came with some discomfort. But that day, her total count was only less than 10,000. PCV was normal, that is almost 34 to 35% only. So I thought just giving her, promoting her with oral intake of fluids and IV fluids, she might settle down. And after 24 hours, she was feeling very comfortable and she went home. She's continuing to have the letrozole. 3 days later, she came with breathlessness. Okay, that is yesterday morning, she came with breathlessness. Her abdominal girth did not increase. There was minimal ascites, but she had developed bilateral pleural effusion. We have
Yes,
to aspirate 1.5 liters of pleural aspirate from either side, and now she is very comfortable. See, I did not want to have an ascitic fluid tapping done for this particular patient because she is not showing any sign of increase in the abdominal girth. So that means there is no like exorbitant ascitic fluid formation. But on the other hand, dyspnea was there. Her SiO2 at room temperature was only 95%. So on ultrasound itself, we could pick up large pleural effusion on either side, and tapping she went on. So that her E2 level was beyond 3,000. Okay, she had say 28 oocytes were there. So what else, how else we could have prevented ovarian hyper? See, though this is a mild form of ovarian hyperstimulation to start with, only thing what we made us intervene was the pleural effusion.
Cetrazole.
Cetrazole,
ma'am,
she was
that's
on
why we
cetrazole.
call it is idiosyncratic to PCOS, irrespective of the doses. It will tend to happen. Our aim is to minimize it and
Yeah.
make the patient's life easier. That's it. But you cannot completely eliminate it that
Completely.
we have realized.
Yes.
You
Even
have to
with
be very
agonist
safe.
level.
That's all that. You have to be very safe. You have to call them back, look for it, and then treat now like how you did. That's all.
You
That's
have
all
to
we
learn to treat because it will keep
Yes.
happening.
Yeah. See, we should not be panicked because in the earlier times, some 18, 20 years back, we had a total count of 25,000 and my physician was telling, madam, it is some infection. I said, no, it is only hyperstimulation. And we did, me and Chitra, we did ascitic fluid
Paracentesis.
tapping, pleural tapping, and even she had some minimal amount of pericardial effusion. To our surprise, that patient, because there was no question of segmental transfer those days. We didn't have that protocol for freezing.
Freezing techniques.
So that she became pregnant. She was a Sri Lankan woman from Canada. She became pregnant, adenomyosis patient, but fortunately, she went home all right. Okay, so this was one. See, then one more question I have for you, Seema. See, is there a role for oral antagonist? Because now we are going to get oral antagonist, no? GnRH antagonist. Can we try that? Are there studies to show that?
Like, yeah, I was looking for the studies, but I couldn't find, apart from one or two paper presentation, I couldn't find, ma'am. And recently for last 1 month, I did not try to look for it. Similarly, the way we are using PPOS, Argolix, and all these oral antagonist trial is ongoing, and
Okay.
near the day is not far away when we might start using that too.
Okay, either elagolix or elagolix, whatever
Yes.
it is.
Yes, ma'am.
Okay, okay. Then Harshini has asked about
the role of letrozole in PP.
So let's not mix many apples and oranges together. Here we are taking two different protocols. We are already taking one thing, medroxyprogesterone acetate or a progesterone, which is preventing the ovulation and everything. Along with that, if we start taking letrozole is an aromatase inhibitor. So it will also increase the androgen level in that follicular fluid, and that might lead to a lot of theoretical bad quality oocytes. So as of now, PPOS, we are not using letrozole during stimulation. We are using PPOS only for conventional stimulation, not even for mild stimulation. Post OPU to prevent OHSS, you can start these patients on letrozole, but please don't mix the protocols.
Okay. So thank you, Seema. I think then for the can modified natural cycle reduce the incidence of epigenetic changes in FET cycles?
And that is not going to decrease the epigenetic changes as much it is going to make this patient's life that all these complications like PIH and anything related to vasculopathy and placental implantation, that is going to be decreased, ma'am, according to me. Epigenetic modification I don't think that it is going to affect much.
But definitely helps in placental complication. That also we see.
Definitely,
Okay.
ma'am. Even
And
miscarriage rate, ma'am.
Yeah. And added to that, we always give a low dose aspirin, which also helps in reducing all these placental complications.
Yes, ma'am.
Chitra, anything else? Anybody? Otherwise, shall we move on to Dr. Tendril? Tendril, please start sharing.
Anantalakshmi had asked one question about something, lead follicle of 18 millimeter had antagonist. Is it so when you add letrozole and HMG or only FSH? I don't understand. What was that? That was what trigger?
Trigger.
What is she asking?
No, it is only for trigger.
Okay. Then we'll move on to the case.
Yeah.
Okay. We'll move on to the case discussion. Tendril,
start sharing your screen. Tendril, to introduce, she is our certificate course candidate from on ICOG. She is an undergraduate student of Madras Medical College and post-graduation from JIPMER, and she had completed her MRCOG also. Seema, you be there. I just want you to be an examiner for her.
Yes, ma'am, I'm here. I'm just switching off my camera.
Okay. Go ahead, Tendril.
Yes, ma'am. Am I audible, ma'am?
All the best, dear.
Thank you, ma'am. Good evening, one and all present here. At the outset, I'd like to thank Dr. Ramni Devi, madam, and Dr. Chitra, ma'am, for giving me this opportunity to present in this forum. Moving on to case presentation. So, Our patient was Mrs. X, aged 33 years, and she has been married for the past 5 years. She is a resident of Trichy, and her education was English, by occupation, and her religion was Hinduism. She came to us with the chief complaint of anxious to conceive. Her menstrual cycles were irregular since menarche, and for the past 3 years, she had only withdrawal bleed. There is no history of heavy menstrual bleeding. Her marital history, married life was 5 years, and it was non-consanguineous marriage. And for the past 5 years, she has been living with the partner. Sexual history, coital frequency was 2 to 3 times per week. There is no history of dyspareunia or postcoital bleeding or coital difficulties. No history of contraceptive. Obstetric history, she is an early gravida. Past treatment history, she has been diagnosed with PCOS outside, and she has had 3 cycles of ovulation induction with letrozole in 2023. However, all these 3 cycles were anovulatory. She has also been diagnosed as hypothyroid 2 years back, and she started on tablet Thyronorm 75 micrograms OD. She has also been started on tablet metformin 500 milligram BD from 2023 after being diagnosed with PCOS. There is no history of diabetes mellitus, hypertension, or chronic drug intake. Family history, personal history, and surgical history were not significant. Coming to the male part, yes, he is IT professional. Medical and surgical history were nil significant. Coital history, there is no history suggestive of erectile or ejaculatory dysfunction. Personal history, he is a non-smoker, non-alcoholic, no history of using tobacco-based products. Family history, he was nil significant. Examination of the female partner, her general condition was fair, she was afebrile, her height was 156 centimeter, weight was 58 kgs, and her BMI was 23.8 kilogram per meter square. Pulse rate was 84 per minute, blood pressure was 120 mmHg, and her thyroid examination was clean. Breast examination was normal, there was no galactoria. Hirsutism was present, and on systemic examination, respiratory system examination, bilateral normal vesicular breath sounds heard. Cardiovascular system, S1, S2 heard, there were no murmurs, and CNS examination was normal. Abdominal examination, on inspection, there was no abdominal distension, no scars, sinuses, or dilated veins. And on palpation, abdomen was soft, non-tender. Gynecological examination, external genitalia was normal. Cervical examination, cervix and vagina was healthy, and on pervaginal examination, uterus was normal in size, anteverted, mobile, and fornices were non-tender. Moving on to investigations, female partner investigation, her blood group was B positive, viral markers were negative, hemoglobin was 11.9, fasting sugar was 78 milligram per deciliter, and urea was 18, and creatinine was 0.7 milligram per deciliter. Her urine routine was normal. For male partner investigations, his blood group was O positive, viral markers were negative, hemoglobin was 14.2 gram per deciliter, and random blood sugars were 13.136. Urea was 19 and creatinine 9. Urine routine was normal. Semen analysis of the male part showed volume of 2 ml with concentration of 24 million per ml. Motility was 22%, which includes both fast and slow progressive, and morphology was 4% of normal forms. So we found that he had asthenozoospermia. Hormone assay of the female partner, FSH was 4.3, LH was 9.4, and serum AMH was 8.9 nanogram per ml. Serum TSH was 2.3 micro international units per ml, and serum prolactin was 21 nanogram. Ultrasound pelvis showed anteverted uterus with the endometrial thickness of 4 mm. Right ovary, there was 25 antral follicular count with volume of 22.9 ml. Left ovary, antral follicular count was 28 with volume of 26.3 ml. So we found that she had bilateral PCOS morphology. So we went ahead with diagnostic hysterolaparoscopy for the patient and found that uterus and tubes were normal. Bilateral PCO was seen. On chromoperturbation, bilateral spillage was seen on both the tubes. We did PCO drilling for her. And in the subsequent cycle, we planned for IUI for this patient. We started to give tablet letrozole 5 milligram OD from day 3 to day 8. And subsequently, we also started her on injection HMG 150 units from day 5. However, during the follicular monitoring, we found that she did not have follicular selection even after 10 doses of HMG. So on day 17, the patient was counseled regarding the same and cycle was cancelled. And in the next cycle, IVF was planned for her. For controlled ovarian stimulation for IVF, the protocol we followed was the antagonist protocol. And on day 2, hormone assay was LH was 7.9 milli-international units per ml, E2 was 24 picogram per ml, and day 2 ultrasound showed right ovary had 22 antral count and left ovary had 25 antral count. So what we did was we started her on recombinant FSH of 200 international units and HMG of 150 international units for 4 days from day 2, and we monitored day 6. Day 6 in the right ovary, we found that she had 4 follicles 12 mm in size, and 5 follicles had size and 8 follicles had size of less than or on the left ovary, we found that she had 3 follicles which reached 12 mm in size, 7 follicles had 11 mm in size, and 5 follicles had size of less than or equal to 10 mm. So we continued the same added injection ganirelix. After 6 doses on day 8, we found 4 follicles reached 15 mm in size on the right ovary, and on the left ovary, 5 follicles reached 15 mm in size. After continuing the same dose for 2 more days, on day 10, we found that on the right ovary, 3 follicles reached 17 mm in size, 6 follicles had 16 mm of size, and 9 follicles had size of less than or equal to 15 mm. On the left ovary, 5 follicles had 17 mm in size, 5 follicles had 16 mm in size, and 7 follicles had size of less than or equal to 15 millimeter. So we continued the same dose for 1 more day, and after 9 doses on day 11, we found that 4 follicles reached 18 mm on the right side, along with 6 follicles of 17 mm and 10 mm. And on the left side, 5 follicles reached 18 mm in size, 4 follicles had size of 17 mm, and 8 follicles had size less than or equal to 16 mm. So with this, we gave her trigger, which was an agonist trigger, injection decapeptide for her 0.2 along with the trigger. On the same day, we started her on tablet gabapentin 0.5 milligram OD for 7 days. Oocyte pickup was done after 35 hours of trigger, and post ovarian pickup, we started tablet letrozole 5 milligram TDS for 7 days. So during oocyte retrieval, on the right side, we aspirated 20 follicles and we got 19 oocytes. On the left side, we aspirated 17 follicles and we got 15 oocytes. So out of these oocytes, the number of M2 oocytes which were available for 20, and we did ICSI for 20 oocytes. After incubation, day 3 embryos were 15, and we did extended culture for all these 15 embryos, and we got 7 blastocysts. In the subsequent cycle, FET preparation was done with HRT from day 2, and when the endometrial thickness reached 9.2 mm with trilaminar pattern, progesterone was started and 2 blastocysts were transferred. After 2 weeks, serum beta HCG was 1724 international per ml, and she had single live intrauterine gestation.
Dr. Seema, now you can start.
Yes, ma'am, I just lost her in the last 2 slides. What was the conclusion? Because a lot of people are just up to me. Can I just just
Tell you, repost the last few slides. Go back, start sharing your screen.
yeah.
So this one, stop with that.
One is LH7.
Next slide.
Yeah.
Hmm.
Yeah. Next, which, follicles 2017, oocyte 1915, M2 20, day 3 embryo 15, day 5 7. Okay.
So FET was done.
Yeah, it was a very well managed case, ma'am. And being a polycystic ovarian syndrome patient, blastulation rate was 50%. She had 30, 20, around 19, 20, 30, 34 oocytes, out of which 20 were, what was the reason, do you think, that you only got 20 M2s?
First, there is poor oocyte quality. That is one thing. And somewhere immature, we got GV as well. So the number of M2 which were available for ICSI, we got only 20, ma'am. This is the number of M2s are always lesser in PCOS patients when compared to normal responders.
Definitely. Yeah. And your embryo day 3 formation rate was also nice, 15.
Quite good. Yeah.
Any reason why, what do you think, why you got only 7 blasts after getting 15 day 3? But
There may be some genetic abnormalities in PCOS oocytes. The quality may be lesser when compared to normal responders.
yes.
Other than that, the male partner also had actinozoospermia. Maybe that might have also contributed.
Exactly. So all good looking things are not the best. So that's the difference why we have started doing day 5 transfers. Because looking at this number 15, a decade back, we would have been very happy, but we would have got disappointment while transferring the embryos. So yeah, that. And what could have you done differently if you look at this patient? ये किसका फोन है यार?
She was a resistant PCOS patient. When she came to us, she had prior 3 cycles of resistant letrozole cycles. So after that, we already she has been started on metformin. So we did PCO drilling in view of lean PCOS with the increased LH. After that, we have given her 1 IUI cycle, but despite adding gonadotropin along with letrozole, she was not responding.
So how much, what was your maximum dose? Was it a step down or a step up protocol?
We could have done a step up protocol for her, ma'am.
कौन लड़ रहा है यहाँ पे? मेरी पर्ची नहीं, आप पैसा ले लीजिए वहां से, जाइए आप ले लीजिए, कोई दिक्कत नहीं है। हाँ जाइए, इसके लिए यहाँ बवाल करने की क्या जरूरत है, जाइए ले लीजिए। Sorry ma'am, I have to say bye. People are creating trouble here. It was a lovely, beautiful
Thank you, ma'am.
presentation, bacha.
Thank you.
And very well managed. Congratulations.
Thank you.
Thank
Thank
you.
you very much. Thank you for taking your
I
time and
have
being
to
with
leave,
us.
ma'am. Chitra ma'am, Ramani ma'am,
Thank you.
bye.
Thank you.
Bye.
Bye.
Thank you.
Bye.
Thank you so much for your presence and your lecture. It was so nice. Thank you. Okay. Chitra, shall we wind up then?
Yes, can
Kendall,
we?
very well done. Very well presented. Probably, as you said, in the ovulatory, I mean, like prior to ART, during the planned IUI cycle, we could have done a step-up protocol.
Okay, ma'am.
Yeah. Instead of 150, the same 150 continuing for a longer time. After initial 5 days of 150, we could have stepped up to 225.
225.
For the next
Okay, ma'am.
3 or 5. Like that, we could have done. That was one thing where we missed it. But
Okay,
anyway, we managed to get the pregnancy for her through ART. Okay. Chitra,
Thank you,
anything
ma'am.
else you want to?
No. Next, nothing special. Any questions from the audience?
Yes. One, excuse me.
Chandra,
Good evening.
Good evening. Good
Yes.
evening, Chandra. Tell us.
Yeah, I have a doubt because to start with LH was high, no? 7.4 when you start your ART, when IVF.
Yes.
But if LH is high, should we add HMG? Because already LH is high, no? Generally, we give mixed protocol, but in this
Yes,
case,
Well,
ma'am, for IUI, when we started, the patient was not affordable that much, ma'am. So we gave her HMG, but since she was not
she is
responding
asking for ART cycle. Because
ART
already LH is high. She wants to know why we combine with RSFH and HMG.
HMG. That LH which is very high is usually because of the resistance that the ovary has. Really, it does not act. So you can add HMG. That's why the results between the HMG cycle and FSH does not differ much.
Does not differ at all.
They use LH in PCOS also. So it
Okay,
doesn't matter. You can use HMG.
Okay, thank you.
That rise in LH is because the ovaries are so resistant to that LH.
But you have already done the drilling, no? Even after drilling, the resistance is still
In
there.
spite of
Hmm?
all the
Yes,
meetings, it
ma'am.
is still
Yeah.
remaining that high.
See, that's what Chandra, we were trying to say, that after the drilling, we should have gone in for a escalating dose of HMG. Probably that might have worked, but still the patient, the partner had got an acinospermia. How far we could have achieved a pregnancy with the
Why
ovulation
we
reduction
do not know.
is
Yes,
doubtful.
because we will refrain from using HMG in this case, but you have succeeded. So
Yes.
we can try. Yeah. Thank you.
Anandi, anything to do with the why there was a disparity between the total day 3 embryos and day 5 embryos? But
Ma'am, no,
anyway,
ma'am. Actually, that is a good blastocyst rate, ma'am.
That's a
Yeah,
what?
We
50%.
usually expect
50%.
around 50 to 60% of blastocysts in a good lab, ma'am.
That's
So
what.
that is a normal rate which we can expect. There is no
That is
abnormality in that,
expected.
ma'am.
That is the expected blastulation rate. Actually, the
And
M2.
one more thing to add, ma'am, shall I, ma'am?
Yes,
Yes,
please.
yes.
Ma'am, Chandra ma'am was asking about adding LH, no, ma'am.
Yes,
Yes.
yes.
In the Seema Pandey ma'am's presentation itself, she told that compared to HMG and RFSH, the abortion rate,
Results are
miscarriage
better.
rate, and live birth rate is
Ah,
better with HMG.
True.
So we need to
HMG.
add LH for every case, ma'am.
Even
Oh, yes.
not for a PCO, they add a little bit of LH because you want to increase the
Yes,
number
ma'am.
of FSH receptors for them to, the FSH to act on the ovary. So you can still add, no harm.
Okay.
Thank you, ma'am.
Okay. Thank you, Anandi.
Any more doubts? No. Shall we close then? Thank you
Yes.
very much, everyone.
Bye. Bye.
Bye.
Thank you for
everyone
all
for
the
being here.
participants for your great
Ah.
participation. Yeah.
Thank you very much.
Thank you and good night.
We'll meet you again next month with another speaker and another good meeting. Thank you.
Thank you. Thank you.
Saviti, thank you very much for this platform. Thank you.
Thank you, ma'am.
Thank you, Sagiti.